Hi Nadira, my 1-year-old daughter has low hemoglobin. The doctors say it's 5.5, MCV 50 plus, and they want to transfuse.
Oh, sorry to hear that. I know last time you told me your baby is born smaller and earlier 6 weeks, right? I thought she was doing fine.
Yeah, I thought my daughter is fine. She's growing well, active, playing around. We just checked because she looked extra fair. Should I just go for transfusion? Or is there a better way? I know you always champion PBM.
Yes, I definitely benefited from PBM. Well, from what I learned from the expert doctors, you shouldn't do a transfusion or liquid transplant just based on numbers. Experienced doctors who use PBM for children have used IV iron or oral iron alternate days. If there is no response in a month, then they use erythropoietin. It works out fine. Do ask your doctor about this.
Thank you for your suggestions. If I have known about PBM earlier, could this have been prevented, and what are my missed opportunities? Apart from that, what more could have been done?
From the curiosity of the mother, let me answer her questions. According to the World Health Organization, anemia is a public health problem that needs to be addressed urgently, since almost half of the children below 5 years globally are affected. In Malaysia, according to the World Bank data 2019, the prevalence of anemia among children between 6 to 59 months is 24.6%. That means almost 1 in 4 children below 5 years are anemic. Now, let us look at the factors contributing to high prevalence of anemia. These include low levels of mother's education, low household income, gender, nutritional status, specifically stunting and wasting, and parasitic infections. Another possible cause is that their mothers are anemic and do not have sufficient intake during pregnancy. Low consumption of micronutrients, that is poor complementary feeding practice, especially iron, in the children's diet may also increase the risk of anemia and iron deficiency. In neonates, anemia can be associated with poor weight gain, decreased activity, tachycardia, apnea, respiratory distress, and feeding problems. In pediatric patients, anemia may also be associated with impaired cognitive and physical development and weakened immunity. Hence, there is a need to anticipate or check for anemia in certain at-risk populations, such as those who were born premature. It is important for healthcare professionals, especially the nurses and doctors, to regularly screen for symptoms and signs of anemia in young children below 5 years old during their regular child health clinic visits. Special attention should be given to those who were born premature. This is due to increased iron demand as a result of rapid catch-up growth. Different treatment options are available. Infants and children should receive sufficient dietary iron to achieve the adequate intake of recommended daily intake. This could be achieved through adequate and diverse complementary diet rich in iron. For infants between 0 to 5 months, they have a considerable endowment of iron, that is about 80 mg per kilo from the mother, and possess a high hemoglobin concentration. Iron requirement during the first 4 to 6 months of life of a full-term infant can be met by iron provided through breast milk, as the total body iron of infants at birth and at 4 months of age remain essentially the same. However, for infants born prematurely or with low birth weight, they should receive additional iron from other dietary sources after 2 months of birth. For those infants between 6 to 11 months, they have an increase in body iron need due to increase in basal iron losses, growth, and the decrease in iron store from birth. In addition to breast milk, iron needs must be met from foods. If the adequate intake or recommended daily intake cannot be met by dietary means, iron supplementation is advised. For infants and children who have low iron, oral iron medication could be given. They should be given 6 mg per kilogram per day of elemental iron that should be continued for 6 to 8 weeks after hemoglobin level is restored to normal. The dose calculation depends on the elemental iron in the preparation, whether it is coming from the syrup ferrous ammonium citrate or from the tablet ferrous fumarate. As for the use of erythropoiesis-stimulating agents (ESA), studies have shown that in preterm infants with low birth weight, ESA therapy with or without iron may reduce transfusion incidence as well as volume. In a nutshell, infants and children with iron deficiency should be treated with iron supplements and dietary modifications. Blood transfusion should be the last resort. The doctors should not easily following the hemoglobin number, but taking into account the number of years ahead the child has in view of the lifelong implications of blood transfusion. So, it is very important to examine the child and look for the cause of the anemia. Do not just transfuse the child based on the hemoglobin value. Blood transfusion is generally not required in chronic iron deficiency anemia unless patient is in overt cardiac decompensation.
As a mother, did you know that iron deficiency or iron deficiency anemia in pregnancy is not only common but has a huge impact on both the mother and the unborn baby? It is indeed a global health problem, affecting as high as 90% of pregnant women in Malaysia. Anemia in a pregnant woman is diagnosed when the HB is less than 11 gram deciliter due to the demand of placenta and the growing baby. Hence, HB target of 12 or 13 gram per deciliter is acceptable as the value for pregnant women. And iron deficiency is when the ferritin level is below 30. A person is said to have low iron stores if the ferritin level is between 30 to 100. So yes, the magic number for ferritin is above 100. However, do remember that an absence of anemia doesn't exclude iron deficiency. And the effects of iron deficiency or iron deficiency anemia is the same. Among the effects include placenta being weak or what we call as placenta insufficiency, increased risk of poor outcome or even death to the mother from excessive bleeding at delivery, increased risk of transfusion. As for the unborn baby, there is risk of miscarriage, preterm delivery, impaired growth, and this carries forward even after a baby is born and right through their childhood, exposing them to anemia, risk of transfusion, behavioral and brain-related problems such as autism, schizophrenia, and other brain development issues. Plenty can be done and should be done to treat iron deficiency even before iron deficiency anemia sets in. For one, we should take iron-rich diet. For example, iron from meat is more easily absorbed and should be eaten more. Also, eggs, dates, vegetables such as spinach are iron-rich. Eat these with drinks that have high vitamin C to help the absorption of iron. Option number 2 are iron tablets. These are best taken on empty stomach, i.e. early in the morning. They can, however, cause some stomach upset or constipation. If this doesn't work, then we will have to resort to option number 3, which is iron injections. And these are usually the most effective method, but can only be given in the second or third trimester, meaning after 12 weeks of pregnancy. Pregnancy is a beautiful journey for both the mother and the baby, and the aim is to reach the destination delivery safely and in good health. As for any journeys, we will have to plan and prepare well. Similarly, if we anticipate, detect and treat iron deficiency and anemia appropriately in a timely manner, we can prevent many complications and also promote good health in mother and baby. By making sure that a mother is not iron deficient or anemic, she will safeguard her baby and ensuring best possible future for her and her baby. Remember, the best blood is your own blood.